morning, good afternoon. I am greeting like Nigeria. Good morning, good
They're in
afternoon, good
Nigeria,
evening.
so no problem.
Wherever you are, wherever you are joining us from. This is Chinasa Imo, the convener of What About Rural Health, but I also do host bi-weekly podcasts with the same name, What About Rural Health. So I'm glad you are joining us for this special conversation as we reflect on Nigeria Health Promotion. I know it was last month, Health Promotion and Awareness Month. I know it was all done all through last month. And Dr. Zainab here has been at the forefront of rural health, and we couldn't be more than happy to bring her on board to talk about her experience. And today's discussion we title it The Challenges of Delivering Healthcare in Rural Nigeria. So welcome, Dr. Zainab.
Thank you, Chinasa. Thank you for having and inviting me. I think it was 2 weeks ago that all this was planned out. So it's not like it was months in advance. So
Yes, I know. So before we dive into the conversation, I would want to let the audience know who our special guest is today. So Dr. Zainab is a young Nigerian medical doctor, very passionate about health equity. She advocates for improving healthcare delivery in underserved and rural communities. She's a graduate of Ahmadu Bello University in Zaria, and her clinical experience has exposed her to a lot of connections between poverty, inequality, and disease. And this fueled her commitment to community-centered health initiatives. She's currently working at the National Tuberculosis and Leprosy Training Center in Saye Village, where she provides care to rural people while advancing public health education. So beyond clinical practice, Zainab is also the founder of Pediatric Oncology Survivorship Initiative. It's called POSI, an online platform that she uses to amplify voices and challenges of childhood cancer survivors. She runs a YouTube channel where she shares compelling stories from medical history, public health, and her first-hand experience working in resource environment. And I would say that most of the videos and pictures that you post are what intrigues me. Like every time I go to your YouTube page or your Instagram page and I see like you telling this story from your own first-hand account, like these are the roads, you can see the bushes, here is the cubicle
you
hospital.
definitely watched the most recent video. That's right.
You know, what got me is that, I mean, we can play around the fact that, you know, many communities do not have care. And the fact that when you show those cubicled four square public health facilities that people go to get help, some people don't know that that is their only stop to
Yeah.
healthcare. Like
Yeah.
there is no other place. Like it's not like this is your first point to step into healthcare. There is something else. Like this is literally it. That's where rural community people go to get healthcare.
Yeah.
And when I see shiny resumes of doctors, medical professionals who are everywhere, high and there talking about medical technology, how that is saving life, I'm like, whose life? I live in urban area,
Yeah.
right? Currently,
You live
in
in the
five
United
minutes,
States.
an Uber can take me to a hospital, and I mean a hospital. But you do this work in this rural environment. I know you find joy because you don't look sad when you show those videos. So
Well,
before
there
we
are
get into
definitely
the
two
heart
sides
of
to
our
a coin, and we'll be discussing as much of it as possible today. There are challenges, and quite all right. Yes, I'm proud and also happy rendering and offering care
yes,
and those services in rural settings, but there are challenges.
I actually wanted to ask you what inspired you to do
Okay.
rural health work.
Yeah, before I answer that question, Chinasa, you said you came across my page and then you're always inspired when you go to my YouTube channel and you view some of my videos. I think I would want to say the same of you too as well, because if I was actually one of your earliest followers
I know.
before you hit 100 followers, if I'm not mistaken. And then I
Yes.
was really fascinated by your the name of your brand. What about rural health? I can remember coming across it for the first time. I was like, who is this person, who picked out this interesting name for their page? Yes, what about rural health? Because it forces you to confront that question. Like, it's not like a very savvy name. It's very straightforward, and is in and of itself, it's quite inclusive. So what about rural health? Like, you stop for a second and you think, yes, these people actually need to get healthcare delivery in those settings, quality healthcare delivery. So I just want to also say kudos to you, because I think you're making people to try and imagine rural health care in a very good light, which is a very good thing. So,
Thank
your question was, I think, what inspired my. I've forgotten how you framed it.
Yeah,
So, could you?
I wanted to know what inspired you to do like rural health work, because like
Okay.
you could have picked any place after you graduated from medical school. You
Yes, that
you could
is.
have gone to Abuja.
Well, maybe I should give some context to this discussion. I would have gone to Abuja, or within where I'm situated, which is Zaria. I would have gone to a tertiary hospital, like ABU teaching hospital, right, where I graduated from. But I think that is a question that I receive a lot. Why did I go to Saye? Why Saye Village? As a medical student, some of the experiences that I went through really shaped my decision to actually serve in Saye.
Mm-hmm.
As a final year, let me even just start by saying that I had my clinical rotations all in Ahmadu Bello University Teaching Hospital. And although Ahmadu Bello University Teaching Hospital is a tertiary institution, it is situated in, I wouldn't really say it's a rural area, but it's also not an urban area. So most of the clients or the patients that it's services are actually from rural communities, right? So that's like my first entry into having to confront patients that come from rural settings. Most of them are impoverished, most of them are poor, most of them are, you know, not as privileged as those who reside in urban settings. However, I think the main experience was a final year posting that I had, called community diagnosis posting. Like,
Mm.
every final year medical student in Ahmadu Bello University goes through that 1 month posting, and taking it's taken under the Department of Community Medicine, right? Ahmadu Bello University. And so in that posting, you choose a rural area where you go, and you conduct health surveys, you interact with women, you interact with children, their health problems, you diagnose community problems, and you kind of implement an intervention. So I think that was my first, I won't say first, that was like that was the major experience that really made me to ask myself, like, rural healthcare is not getting as much attention as it deserves, and there are a lot of problems that most are preventable. So how can we provide solutions to this problem? So I think that's what really inspired me, that community diagnosis posting.
Thank you very much, Dr. Zainab. And if you are watching, this conversation, please let us know where you are joining from. Drop us a comment section. Also, feel free to ask question, and if you want to come live, just notify. And at some point, when we are into the conversation, I will bring you up on the screen to ask your question with Dr. Zainab if you would want to. All right. So you work every day in Saye Village, Dr. Zainab. Can you tell us a little bit of what healthcare delivery looks like over there?
Okay. Um, well, I think I need to be giving some form of context for some
Mm,
of the questions. So, I work, as you've mentioned previously, at the National Tuberculosis and Leprosy Training and Referral Hospital, and it's located in a village called Saye. And fun fact, it was actually um, a leprosy containment, or let me say camp, and it
mm,
has been around for over 100 years. I mean, it was actually run by missionaries before it became subsumed under the National TB and Leprosy Control Program, right?
yeah.
So, and it's actually like a referral hospital. So it's a large hospital. It's just like it's situated in a rural setting. However, one
Mm,
of the service delivery points is the community healthcare center, right? Because I kind of like to imagine it as a corporate social responsibility to the
mhm,
community, even though it's like generally part of the plan because it's a TB leprosy training center, and it's responsible for training, retraining of human resource for TB, leprosy, and also HIV. So HIV is included. um you know like every like most healthcare centers, there are departments, right?
yes.
So it has a lot of departments. It has the monitoring and evaluation, it has labs, it has the uh, TB labs, it has the general laboratories, it has, the administrative block, etc. We have the GOPD and also the community healthcare center. Now, for the community healthcare center, to we have labs like the where common conditions like malaria can be diagnosed through rapid diagnostic test. Also has a pharmacy where they're essential drugs, right? It's primary healthcare, so and one of the components is, yes, having essential drugs. Um, Most of the diseases that I see are preventable diseases,
Yes.
specifically infectious diseases, specifically diseases that you see in poor people. So
Mm,
those are the type of patients that I consult. Now, in addition to having doctors, most as with many primary healthcare centers, they're mainly manned by community health extension workers, community health officers, CHUs, JCHUs, lab technicians, etc., and then some nurses. So some of the services, because you mentioned what healthcare delivery looks like,
mm,
include, we offer reproductive health services, including family planning, routine immunization, what else? Diagnosis of common or endemic diseases, and then consultations, which is what I do most of the time. So I think that is what healthcare delivery to me looks like. I've essentially summarized what I think.
thank you so
Are
much
important.
for thank you so much. Like you really gave us a clear roadmap of what not just like a delivery, but what it looks like in Saye.
Yeah,
And I remember in those my history classes as a public administration student where we talk about, the impact of colonization and the whatever it is that they left us. And you know part of that is having these huge hospitals
yeah,
that the missionaries set up in different parts of the world. In Africa, um I would say for their scientific advancement, for their treatment, and for making sure that their slaves are just a little bit healthy enough to continue to do the exploration. So I'm just going to make that clear. But I'm glad that they leave those facilities for
Yes.
us and that we are able to also pick that up and continue to expand upon it and establish health institutions within that, especially in rural care. Because if I imagine the Nigeria of today, which government would want to have a political, interest to go and site a huge hospital in Saye Village? So
Yes.
thank you very much for giving that account. So I want to ask, because this is something that we often, don't pay attention to. Like, what does a typical day look like for a health worker working in this environment and also for their patients? Now, this is not about what care setting is made available, but what does a typical day when you wake up, dress up, and go to this hospital? What does a typical day look like for you and the patients who come to get health care over there?
Well, I would just like to say that, as on a general note, it may vary across our experiences may vary across different primary healthcare centers, because some are really far-sighted while others
Mm,
are, closer to urban areas, and that will determine the workload, that will determine the type of patients you see, that will
mm-hmm.
determine the funding and the opportunities that are available. So it actually varies, and our experiences may be different. But I will be sharing my experience. So I think for me, a typical day would be, waking up and getting ready and, driving to work and reaching my place of work maybe by 8:30,
Mm-hmm.
um, maybe 8:30, 8:45. I think that should be a fair range to describe it. When I get there, just for me, I prefer to scan to see how many patients are already there. Most of the time, it's something that I wouldn't say I'm overwhelmed by, because Saye is actually a very large center. And
Okay.
across, yes, over the years, we've had um like renovations, and even the road has now been repaired and tarred, unlike previously, and a lot of, all of that. So I, greet the people I have to greet, and then settle into, you know start seeing patients. There are usually nurses out there who
Mm-hmm.
take the vitals, and then the health information staff who take their data and then submit the cards. We do not obviously use like electronic health records, because it's scarcely available even in tertiary hospitals in Nigeria. So I'm not even going to mention that.
Mm-hmm.
So yes, and I just begin to see patients. So now I rotate between seeing patients in the GOPD,
Okay.
right, and also the community health care center. So I'm not always at the community health care center. I'm sometimes stationed at the general outpatient department, and at the general outpatient department, I mostly see adults, while in community health care center, I see pediatric patients or children mostly, and
Okay.
few times I see pregnant women. So if I'm at the general outpatient department, I see all sorts of patients. I see TB, I see leprosy, few leprosy patients because they are not
Okay.
as many. I also see non-communicable diseases, because it's a general outpatient department. You have to collect the patients and take the clinical history before you even know what is wrong with the patients. So
That's true.
definitely anybody coming with cough, you'd have to check whether it's of cardiac origin or it's from the lung and all of that. So by virtue of that, I see patients from across board, and then I refer. If it's for our center, I order appropriate investigations, and I refer the ones that is beyond our center. I see a lot of women too. Yes, I see a lot of women coming with these conditions, TB, the HIV. So it's not only antenatal cases. Then I also see a lot of dermatological conditions, mostly, as I've mentioned earlier, fungal infections,
Mm.
scabies, etc. Things that are quite preventable, things that, good hygienic practices can actually take care of. So I think when I see patients for about 4 to 5 hours, depending on, it depends. Sometimes
Okay.
if there are
So
many,
can
I,
you give
I
me a number of within those 4 to 5 hours that you see
yeah.
patients? What are like the total number? Say on a typical day that you have a minimum workload. I don't want to go to like maximum how many so that people will be like,
Yes,
oh my God.
minimum.
So yeah.
Yeah, minimum. Well, I'll give
Not
you a range
minimum.
of,
Yeah, yeah, medium, like a
okay, like
medium
I would
range. Yeah.
say I would say, because we do have staff, I think on ground there's usually not less than three doctors in the
Okay.
GOPD. So I'll say maybe like 30,
Wow.
maybe like 30.
So I'm just doing the WHO estimated math of if you see a patient a minimum of like 15 minutes per patient, that which is like, 15 minutes not enough, but that's like the minimum standard that we are calling best practices, right? So if I do the math in 5 hours or 15, ha- okay, so that would be about that
Yeah.
number or less or more,
It could be less. It depends on,
the
I'm not
inflow.
really thought about an average, but
Hmm.
I do know it depends on the case. If it's a
Okay.
straightforward case, I'm done seeing the patient in like 10 minutes,
Okay,
right?
okay, okay.
Yeah.
Thank you
So
for creating that perspective. I just want to know why I'm asking this. I know you are in a like a bigger facility, but it
yeah.
also brings like a high volume kind of patient inflow because it's like
Yeah.
a big hospital. I've been to a lot of northern
Oh,
hospitals. Yeah, I've worked in where have I worked now? In Adamawa, Gombe, Bauchi.
our
Yes.
northeast. You've been,
Yes, and then
yes.
in Niger State. So, and like I know what that workflow look like on a typical day
Hmm.
in a hospital. So that means on an average you see normal patients as it's supposed to be. But like you said, you have staff, you have other doctors, so you alternate. But I'm now going to put it like assuming you are in a place where you are just the only doctor, the general practitioner, because that's what you're explaining to me. You see literally everybody from dermatology to maternal to neonatal to child care to literally everything, and that is what we see in most rural environment for people who are wondering like, oh my God,
True,
even
true.
when even when in specialist hospital, that is what care look like in that space where people just walk in because they want to get care. So it doesn't really matter. And you can't tell them to go away just because you are an oncology specialist, right?
You
So
have to see, nobody knows you're an oncologist, nobody knows you're a specialist doctor. All they know is that you're a doctor. Yeah.
exactly,
Yeah. So
exactly,
if you're
exactly,
able to offer the minimum, even if it's just resuscitation, you have to offer it and just send them to a bigger facility. If
exactly.
it's something that you cannot do from the get-go, then you just tell them to just go to another facility or you refer them.
Thank you so much. Thank you for clarifying this. If you are joining us, I'm discussing with Dr. Zainab, and we are talking about the challenges of delivering care in rural communities. So feel free to drop a message, drop a comment, tell us where you are joining us from so that we can say shout out to you. I am anchoring this on Ruralist Health, but this is a program from What About Rural Health. Thank you very much. So, Dr. Zainab, let's move to the challenge, let's dig into the challenge of this conversation. So, from your perspectives, what are the biggest barriers to making, access to care? What are the things that is making access to care very difficult? Is it infrastructure? Is it workforce shortage? Is it stigma? What exactly it is when you look across like Nigeria and rural healthcare delivery?
Well, Chinasa, I am just going to go straight to the point and tell you that is multifactorial. You know, except if you put a gun to my head and tell me that I have to choose one. But it's a combination of a lot of factors, right? And it cuts across different sectors. It's not only the health sector. When you
Mm,
think about offering or delivering healthcare in a rural setting, you're thinking about things like nutrition, right? You're thinking
mm-hmm,
about things like hygiene, like you're thinking about things like ventilation, pollution and good sanitation, good potable water and stuff like that, right? Things that are required to prevent diseases. So I think right off the top of my head, I'm going to start by saying workforce shortage.
okay.
Which you know that doctors in Nigeria are currently on strike, right?
Oh
Although
my God. Okay, on
you
top of the wahala, doctors are on
resident
strike.
doctors have gone on an indefinite strike. So, although I know that a lot of resident doctors are not stationed in primary health care settings, but
Mm-hmm,
you can only imagine the referral cases that will not be seen, referral cases from primary health care centers that will not be seen, right? But let's even leave resident doctors out of the equation. Let's talk about other cadres. We're talking about community health officers, choose technicians. Those cadres are also not in adequate numbers as we would have it, right? And even if
mm-hmm,
they're in adequate numbers, the remuneration that they get sometimes is not enough to compensate for the distance that they have to cover to go to those rural facilities.
mm,
That's one. Apart from the workforce shortage, there's also the issue of redundancy, the knowledge that they have becoming redundant because
mm,
there isn't consistent training and retraining and updating of the knowledge of the other cadres that are stationed in these primary healthcare centers, right? So, which is
mm-hmm,
a big problem because every, you know, medical knowledge is evolving. So if we don't train and retrain them, there's no way we can even expand the workforce and even talk about task shifting our
yeah.
roles, yes, as doctors. So I think that's a very big issue. I would say definitely the issue of infrastructure is also there. I happen to work in a community health center that is in a tertiary facility. So ours isn't really as much in a bad shape as other primary healthcare centers that my colleagues have worked in or are working in, or
Mm-hmm,
some that I have seen in, like, on social media and all of that. But I would like to say that even in my own center,
okay.
there are some services that should be working but aren't working. Like women, there aren't really enough facilities for women to even come and deliver. Apart
Wow.
from the workforce shortage, yes,
Mm,
there aren't really facilities. The room is there, the bed is there, but the other components of offering maternal health care, labor and delivery, they are not there. Do you understand? And even
yes.
if they are there, the staff that are going to actually perform these procedures are in very short numbers. So
Hmm.
that's, I think, workforce. I've mentioned workforce shortages, infrastructure, and well, governance, political will is another important factor, really. And I would also say, I forgot to mention one important thing would probably be the social cultural aspect,
Okay. Tell me more.
the community participation,
Mm-hmm.
and the the utilization of those services, right? And sometimes I feel like I think to myself, is it that people don't know that some of these services are free? And then when I talk to those patients, I realize that some of them know that they are free, but especially
Mm,
for women, which is something that I'm passionate about,
yeah.
it's like they are socio-economically disempowered to seek care in those settings, right? You're talking
Mm-hmm.
about, let's say, because women are the primary caregivers, you're talking about women bringing their children for routine immunization, and they want to do it, but their husbands have not given them consent to go and.
Commission.
So yes, and then the utilization of traditional medicines, herbal medications, is really stalling and really slowing down the proper and adequate use of those healthcare services, even the ones that are available. So I think off the top of my head, that is what comes to mind.
Thank you. And if I can recap what have come out from the top of your head is this. Number one, there are no workforce. I mean, if they are a workforce, there should be more medical professionals who are attending to these health cases. But one thing that I picked out of your explanation is something that I called package, bandage, and ship. Now, if medical practitioners are busy doing package, bandage, and shifts because there are no workforce, right? It's like only you in the hospital and you have 100 patients or 70. Say it's a day with low inflow, you have 40. It's only you juggling. So, what are you doing? That's what you're doing. What is this person presenting? Okay, let us do a little thing. Let us package, let us shift. While you are juggling that process, there is no time for improvement of knowledge. There's no time for you to even advance your technological know-how. There's no
And even
time.
if
Like,
you try to do it, you're going to do it at the detriment of the patient.
exactly.
Yes, because you
Exactly.
must find,
Because
if you decide to find time for yourself against the number of patients that you have, it will be at the
exactly.
detriment of the
So
patient.
it's
So
now
it's
between
either
what
that
should I
or
do?
that.
Go for more training or just keep packaging and bandaging? And with that, many doctors, and I'm saying this in like very sincerely. I have been in the space where I've seen doctors go like very depressed and emotional because of one, they cannot help the environment that they are in because of the situation. And you mentioned political will, because of the situation that is created by either policy or political spaces that they work in. But they also care so passionately about their patients that they know that they can't risk it to go pursue personal growth and professional advancement, which in turns would help the patient. But it's like if I go to aspire to be this bigger doctor and I come back and all my patients are dead, what would I say? So it's just always this juggling, and you find like primary care doctor, general practitioners, nurses and midwives, all of these caregivers, I'm putting them all in a bucket, juggling every day just to maintain the status quo. So thank you very much for lifting that information up. And I know that you work in a TB space, right?
Yes.
Even though your primary care space does other things, and TB is a very sensitive conversation, at least still in Nigeria.
Yes.
Even when we know that we have advanced, like people should openly, it's
Nigeria
like
is
talking
one of
about
the high
HIV.
burden countries for TB. Yeah,
Exactly.
one of the
So
high burden.
what is the challenge that persists in TB treatment, and how does that shape how people seek care, like their health seeking behaviors? Do you find like things like stigma, misinformation, or distance, to be part of the things? I mean, you can put other things. I'm just signaling things that I feel could be or could potentially be one of those challenges. But what are other things that you see that's keeping people from accessing care very early? Because I know TB, if you come as early as possible, it can be addressed as quickly as possible as well. But you are the professional here, so walk us through
Yeah.
this.
Okay, so I think I'll begin by saying, a lot of things cause cough. right?
Yes.
There are 1001 things that can cause cough. So I think the mere fact that TB looks like other conditions, like I'm talking from a clinician's
Mm.
perspective sometimes,
Mm.
may really delay people from seeking care. People think it's common cold. Do you understand?
Mm. Mm-hmm.
And they only really start to take their health seriously when they see that the cough has been around for like 3 months. 3 months is quite a while for you to even spread the disease itself. Then
Mm-hmm.
apart from that, I mentioned something earlier, and which is the fact that people don't usually go and seek care in in hospitals. They usually access traditional or herbal medications instead of orthodox medicine because
Mm.
it's easily available, it's widely, it's accessible, it's cheaper, etc. And other people would, by word of mouth, people tell you, oh, I had this cough and I used this medication, and then that was another issue is the proliferation of chemists.
Ah.
You understand? People
Mm.
that is one really important factor. I'm even sorry I missed it out when I was talking about the barriers to care. And the fact that they can get these consultations in these shops, these chemists, these small pharmacies where people who man them are really unauthorized to even give some of the medicines that are there. So, well, for stigma, you mentioned stigma. Well, if you had mentioned HIV, for people
Mm-hmm.
living with HIV, that would have been a different case because there's a
Okay.
lot of stigma for that. But with TB, I wouldn't really say I've really had conversations with patients where they've voiced out that stigma really prevented them from coming to the hospital. The
Okay.
ones that usually come to the hospital early enough would usually tell you that, oh, somebody I knew had TB, and
Mm.
now my child is coughing, or now my wife is coughing, or now my husband is coughing. That is why we came, because that person had tarin fuka. Tarin fuka is TB in Hausa. So
Okay.
those ones that do come early, yes, most of the time are usually aware, or they've had someone else who has had TB that that has informed them. Or
Thank you.
few people have good health seeking behaviors. So when they've noticed that I've never really had cough and all
Mm.
these symptoms, fever for this long, I must definitely seek care in the hospital. So few people do have health seeking behaviors, and we have them. People who come from rural communities who actually have very good health seeking behavior. And as a clinician, when I consult those type of patients, I'm usually very happy and ecstatic. And I tell them that they're really doing a good job for seeking health care very early on in their disease. So I
Thank you
think
very
that,
much for highlighting these people. And there is actually the culture that we want people to cultivate. Like when you started mentioning that, cough can be anything, I'm like, is there
yes,
any sickness? Like, I have not seen any sickness, any disease, any infection. In fact, I feel like if your body is just tired, it shows up in cough and catarrh. So it's like the common signs that your body is getting bad. But the thing is, people play down on, oh, it's just cough and catarrh. But
yes,
how about we, when we notice this, and just for the sake of ruling out every other thing, go to the hospital for medical checkup. So that is what I would be asking us as a people, as a country, as Nigeria. When you have most of these things, it could be small, it could be a large thing. I'm not wishing for it to be a large thing, but these diseases and infections exist. And the only way we can catch them is when you run to the hospital. I think between the first 72 hours of feeling the way you feel, please go to the hospital. If the doctor said they didn't find nothing, go home and relax. Enjoy your, hot water, ginger, kind of whatever that you now want to go and do, because the doctor have looked at you, or the medical people have looked at you and find out that there is nothing to worry about. Then you can do this other thing that you feel comfortable doing. All right. So thank you
You
so
know,
much, Dr.
Chinasa, let me
Z.
let me just quickly interject. You know, sometimes I really sympathize with my patients, and I usually look at things from not from a selfish perspective,
Mm-hmm.
because I look at it in the sense of I have foundational knowledge, and these
Mm-hmm.
patients don't really have. Like I'm in the health field. I'm a doctor, so I'm privy to knowledge that a lot of people don't have in the community. And
That's
so
true.
when I see them, I look at them through the lens of, hey, these people don't really have this knowledge, so how could they possibly know? Right?
Yeah.
Yeah, so I think it's also encouraging for other healthcare workers to approach it from that lens, or let me say that perspective, that you have knowledge, which is a privilege. They don't have that. So, in as much as possible, when you do have time, try as much as possible to explain things to them in such a way that they can understand and they can make use of in the future.
Thank you so much for, you know, steering us towards this direction, because that's definitely the next thing that I want us to talk about. How do we create awareness? Because when people don't know, they make the decisions within the ambience of their knowledge. And
Yeah.
part of that is what they see in society. For instance, if I am coughing and I go and tell my mother, who doesn't know that much, my mother will drag me to a medical, to a traditional, person who can mix one and two herbs. I want to
Yeah.
make it clear that we don't, at least from my own health perspective, we don't say that those things don't work. But it's not all of the diseases that get one medical treatment, which is why science
Definitely.
has progressed to begin to figure out what are your symptoms. First of all, what are you showing up with? One, what is it showing those medical doctor or those medical professionals? What are they tying those symptoms to? And what is the best combination of treatment that can get directly to the problem, instead of a blanketed treatment that you don't even know whether it's going to work or it's not, whether it's going to work or it's not going to work. So,
And
which is
even
why,
the fact that you don't even know the dose. Are you
exactly, the
overdosing or
dose
are
to
you
come, yeah,
underdosing?
exactly. They just
Exactly.
be
You don't
like,
know the
drink up,
content. Exactly. So
drink
what if it's
up.
something that could damage your, I mean, if I'll probably tell you that most of the work and the counseling I do is within my consulting room. I mean, at the end of a day, honestly speaking, my vocal cords are probably hurting. Do you understand? Because I literally
I
I
understand that
literally,
from a
hey,
patient's
this is not
perspective.
this is not that, this is the right approach, this is that, this is why you should, like, most of the time I try as much as possible to explain concepts to them from the scratch, just so that they understand. Yeah.
So thank you very much. Someone on the comment section make a good comment that I want to highlight, and I think it dovetails well with what you said earlier, Dr. Zainab. So Ijaik says empathy guides us in the way we treat people. When we show empathy, it will be easier for patients to be at home in receiving treatment, and that is healing already being achieved in the first instance. And I definitely agree with that, because like if a
I
patient
agree.
is seeing you and they are
I
comfortable with you, that's the first step to their healing
I
process.
agree.
So I
So
agree.
I'll even tell you, let me just add that his point actually made me to remember a barrier that is experienced by people in the community accessing and healthcare, quality healthcare delivery, and that is the attitude of the healthcare workers. You know, a
Yes.
lot of them will tell you that they don't like the way the healthcare workers are treating them. They are sick.
Mhm.
You know, there's a way that you lead on and you explain to a patient, and that patient will even respect you more. And
That's
then
true.
there's an attitude that some healthcare workers are very fond of, and it denigrates the patient and it disparages them. And some people actually get angry and because of that decide not to seek care. We see that quite often.
A lot.
Yes.
See, so you're
Thankfully
talking
for us, we
from
address things like that in our facility
you're
continuously.
talking from a rural perspective of like people with limited knowledge and understanding. I have knowledge and I have been in the health work environment for over 15 years now. And I would tell you for a fact that I have stopped going to a hospital, seeing a doctor, requesting to change a
Wow.
a care team because of the attitude of a medical doctor, because of the attitude of the care provider. So that is extremely important to care. Like, you have 10 minutes to change the life of somebody, or 15 minutes if we are going by WHO standard, right? In consultation, to change the entire course of treatment of a patient. Why
Yeah.
not use it wisely? Why not make the person feel at home? Why not apply, the psycho, educational, the biopsycho educational parts of medicine to make sure that this person not only receive care, but receive dignified and respectful care. That's all most patients are asking for. And when they don't receive it, the next
Absolutely.
time they won't show up.
Absolutely. And you know what? If anyone who has ever practiced in a rural setting will tell you how welcoming patients from rural settings are. In fact,
Yes,
despite having very limited resources, when you treat them right, some of them gift you things. They bring you
that's
things
true.
from their farm. So
That is
things like
true.
that really warm my heart because it just shows how grateful and how willing they are to appreciate the services that you render to them, despite the fact that you're being paid. But some people go that extra mile and they even gift you things, and then you are
Yeah,
like,
because
no,
they
thank
know
you.
the
Not
pay
taking
doesn't
out part of
equate.
myself.
They know the pay doesn't equate the care that and the way
Yeah.
you make them feel. Is that
Yeah.
thing that we are removing feeling and replacing that with so much embodiment of data that
Yeah.
X me with medicine. You know what I mean? Like, there is still that thing that comes with human feeling, human emotions, human behavior that we should bring back into medicine. And so, now that we are here and we are looking at the challenge with health promotion in Nigeria, Dr. Zainab, and I know that you've used creative way. I mean, we are here today because of your creative processes of getting people's attention to access care. I wanted to ask you to share two things. First, how do you think the Nigerian health system, including like the Ministry of Health, like all the way to the, strata, can improve health promotion and health awareness in ways that gets people to change their health seeking behavior? Because what we're currently doing, I don't know how much is working. I don't know what buzzing is all about, but I
Yeah.
think that we can re-strategize that though. So from your perspective, how do you think we can re-strategize that? And while you are at it, you've used creative ways, storytelling, communications to do this health promotion. Can you share an example of ways such has made a difference so that people, even fellow medical doctors and healthcare practitioners, will know, oh, I can really apply this in my place of work and make the whole difference that I need in delivering care.
Okay, so I also do not have data to back up how much improvements have happened over the years in delivering care and all of that. But I think from a standpoint of someone practicing in a rural setting, I would say we should include the communities more in our decision making
Okay.
processes. And as even part of the core pillars of primary health care and all of that, I think there's this aspect of community participation, because every
Mm-hmm.
community is different and the needs of every community is different, right? So I think having frequent and consistent dialogues in the face of evolving challenges that the communities face, and analyzing the services, re- analyzing and re-strategizing, and that cycle is really, really important. Then also, you know making the community understand that they have a very huge role that they can partake in
Mm-hmm.
preventing diseases, and that the primary healthcare facility in their community, or the primary healthcare facilities, shouldn't only even be used only when they are sick. It's also meant for preventive services as well, and even counseling and seeking advice and all of that, right? So a lot of people don't know that these primary healthcare centers are not mainly for curative purposes. One of the main pillars is actually to give preventive and promotive and also curative services. So people should know that. We should also try as much as possible to involve community leaders and also women. Give if for example we're forming forums in the communities to address health challenges, women should be a key part
Of that
of,
conversation.
yes, of that conversation. They must be part of the population that would advance whatever solutions that is to come from that community. Then I think the other thing I'm going to say is, sometimes there's this fragmentation I've noticed within, like, centers, right?
Mm-hmm.
Which, between primary healthcare centers, I feel like there should be better, you know, communication between the primary healthcare centers, such as, even if there are things like outbreaks, we can communicate. Like, there's currently a diphtheria outbreak
Yeah.
in Nigeria, and it has actually been ongoing for the longest time, but because there's that fragmented communication system,
Mm-hmm.
other healthcare primary healthcare facilities would not be able to be informed on time. So I
Mm.
think try as much as possible to synchronize, the healthcare communication between facilities is something that people also overlook.
Mm-hmm.
But I think there's this thing called primary healthcare under one roof.
Yeah.
Yes, I know you must have
I
probably heard
worked
of
on
it.
that. I worked on that
Oh,
policy,
okay.
yeah, a lot at the national level, and then
Okay.
domesticated
Okay.
it around about 11 states in Nigeria. Yeah. So I'm
Yes.
very much familiar with
Yes,
PAC.
so I think
Yeah.
that
Under
will
one roof.
probably need to be strengthened. Yes, since there's already a framework
Yeah.
already, there's already that in place. So I think what it needs is for it to be strengthened as well. Then funding, you know, financing,
Mm-hmm.
financing and governance, political will. It has to come from the top,
I
because
I agree.
the people at the grassroots level can't really do so much for themselves, if even if they want to access care, even if they are willing to access care, if the funds are not there, if they've not been dispersed to the primary health care centers, and if they're not managed well, it's still going to collapse. So I think
I
those
agree, and I'm glad that you mentioned PAC under one roof. I don't know what where that is, and I just want to tie your conversation with the policies we make and the funding, but also, and like, I love the way you put them together, the political will. And for many of you who don't know about the PAC under one roof trend, so the government and some partners came to put together this thing, very beautiful policy for the primary health care. The Bill and Melinda Gates Foundation, where I worked under their projects, um, put in a whole lot of money and wanted government to commit some level of money to put this. So it begins to pilot. These are all tied into the National Health Act, the National Health Act, the Basic Healthcare Provision Fund. Like, I just want to make sure that I tie all of this into one bucket. The Basic Healthcare Provision Fund, the domestication of primary healthcare and having minimum service package that all PHCs deliver in the care, and then setting up different accountability measures. All of these things are put under PHC under one roof. Why? It's so that we have an arc like a house that houses everything, and within that there are spectrums where people work but they come together, and that is where you are trying to take up those fragmentations that we see, right? And then begin to ask ourselves, so what care is most needed at what cadre, and what's level of healthcare practitioner are going to deliver those care at
Yeah.
those different cadre, right? That is where you have the tax shifting, tax sharing formula. All of these things, they're all like, it's a whole gamut of, I mean, we can take a whole course on
Yeah.
all of these things in Nigeria. Very beautiful on the ground, very beautiful in the paper, in the policy, but like my previous guests who say, we are beautiful with designing policies and programs, and then we package it, we bind it, we do some razzmatazz launching, and then we shelve them, and that's the end of it,
Yeah, we
right?
don't go back to we don't revisit and try to analyze and effect
Exact,
those things that are not working.
exactly. Now the
And sometimes
problem,
even contextualize them. Yeah.
yeah, but where I'm even driving at is the political will of government, because at least when I was working on that project, it was really driven by external funding. Like
Yeah.
when you see us, someone like me was an advisor from the Bill and Melinda Gates Foundation Fund, right? Driving the push for this bill to for these policies to get across the different states of Nigeria, right? And the government is okay, we will do it. We will do it to the extent that partners are willing to give you funding. That is an eyesore for a country of over 230 million people, with sovereignty, with government who wakes up every day and call us dear fellow Nigeria.
Yeah.
Partner funding should not drive our healthcare. I keep saying that. I'm not
Yeah.
saying we don't need partner funding. We do need them, but it should not drive our healthcare. And that is why we are here, because there is no structure set up by the government to continue to sustain those processes when these, arrogant forces pull out their money or choose to redirect their interest, or, whatever, however they feel, because they can wake up and be like, we don't want to fund Nigeria anymore. And your
Chinasa,
entire system collapses. And
exactly.
that is the challenge that we have with primary healthcare delivery. So thank you for bringing that up, even though it's not what we are, but it
No
angers
problem.
me when I see the way that we
Yeah.
take lip service to healthcare in Nigeria, especially primary healthcare. So let's pivot to something exciting. I know we've talked about barriers a lot, and the issues of Nigeria could be unending sometimes. So you run a YouTube channel and you
Yeah.
led Posse. Tell me a little bit more about it. How do you use these, digital platforms to help reach and educate your audience and your community in ways that traditional process of health promotion is currently not doing?
Well, um, you know, I have my platforms, my online platforms. I'll try as much as possible to be modest. Aren't ones that have a lot of follower counts, right? So I haven't really. I won't say I reach the most people.
Mhm,
However, what I mainly do on those platforms is to share
mhm,
my own perspective and my own side of the story, right?
mhm,
And the things, as you've mentioned, varies. I talk about uh, patient experiences. I talk about the experiences of doctors like me, I talk about other interesting things that are not even related to my work environment, such as medical history and all of that.
Okay.
So most of the patients I have been able to reach at this stage I am in my career and in my journey haven't really been through those online spaces, I would say. Truthfully speaking, most of them have been through physical or interfacing conversations or community outreaches. But the reason that I started those platforms was because I recognized that social media is a very powerful tool in
Mm-hmm.
trying to communicate to virtually, you know, all ages, right? From young minds to even the elderly minds. And it's a very interesting and accessible, accessible in quote unquote, of disseminating information, because mobile usage is increasing across
Yes.
Nigeria and even Africa. So I
Mm-hmm.
think taking advantage of such a platform can really revolutionize how people seek care and how they access care as well. So I think that's what I can just say about that.
Thank you for sharing that. Like you, I know you started very modestly, and I just want to throw it out there that my belief system is that just like what we are doing, we could have only 5 people viewing, but out of those 5 people viewing, one person will take out a life-saving lesson, and that is what matters to me. And if we begin to now aggregate the ripple effect of that one person's
Person.
action, you will see they have magnitude, you know, impact than even you as a person who is not really paying attention to those impressions would do. So I just want to say, like, don't be modest. I follow your work, right? And I
Thank
see what you
you.
do. And I didn't even know you from anywhere. Now imagine
Yeah.
other
Yeah.
people who go through your work and the impact that you leave with them and the way that you communicate through your channels to them. So I want to, now we are moving to reflections and closing. Dr. Zainab, if you have a magic wand with powers, and this may being so fictional, right? If you have a magic wand with powers to redesign Nigerian health promotion and care delivery strategy for rural community, what would be the one thing
Hmm.
that you would change or that you would prioritize first?
Wow, that's a tough question.
Yes.
One thing.
Yes, just one thing. If you have a magic wand and you can only apply it once, what would be that thing that you would change? Or at least, what would be the thing that you would prioritize to do first?
I think um I think something for me, I'm going to choose one thing that I feel sums up all the others, and that is management, governance, or political will. I
Mm,
think is all encompassing,
mm-hmm,
because if you have someone at the top who is really passionate about seeing communities or health in communities prosper,
mm-hmm.
then by all means that person would try as much as possible to, you know, brainstorm ways that would even lead to more healthcare financing, right?
Mm-hmm.
And having someone who is on top, as Nigeria would say, on top of the matter, would
Yes.
sort of trickle down from, yes, would trickle down from the top down to the grassroots level.
Mm-hmm.
I think if I were to say something else, I feel like it will not be all encompassing.
That is
Yeah.
perfect because
Yeah.
that's just it. Like, I like the fact that you tie this conversation back to health financing. Like, all of this thing has to do with health financing, and somebody needs to have the balls
Yeah.
to prioritize programming, service delivery, and every other infrastructure that has to do with healthcare. And those things comes with money. We are talking about low health workers shortage. We're talking about no life-saving equipment in the hospital. We are talking about roads. We are talking about inaccessibility. We are talking about language differences. There are different things, and all of these things ties to money. With money you can hire um more health workers. With money, you can train them more. With money, you
Yes.
can buy all those equipment. With
And
money, you can make roads accessible at least. With money, those hospitals can have
yeah.
water,
With
running water.
money, with
In
a,
fact, you can even
yeah,
begin to think about landscaping when you have solved the core structural issues that needs to happen in the health facility for quality care to be delivered. So I absolutely agree with you.
I would also like to add that with political will, there's an opportunity for also intersectoral collaboration.
Exactly.
So
Exactly.
that's another important addition, I guess.
Exactly. Exactly. Thank you so much. But we're not going to leave on a wish note. So, when let's look at the bright sides. When you reflect about Nigeria health systems, their health promotion campaigns, and everything, what is that one thing that gives you hope about the future of rural healthcare?
The people, the people
Thank
in the
you.
communities.
Thank you.
I feel like
Thank you.
they are having a reawakening.
Mhm.
Do you understand? With like the accessibility of social media, with accessibility of educational services, health promotion services, and even with more people and more organizations reaching out to them, I've seen like a reawakening in
Mhm.
in in the attitude and health seeking behaviors of patients I see in the clinic. They are more willing, they are more understanding to access orthodox medicine. There are people who are really reluctant, but the overwhelming majority, honestly, when you explain to them, they understand, and some of them access those services, vaccination, allow their wives to also access maternal health services and all of that. So I think the people give me hope, honestly.
Thank you. I, I
Yeah.
I agree with you. I agree. The level of resilience, I think we should test Nigeria resilience system. Seriously, it should be studied. Like the whole scientific community of this world should just go and study Nigerian resilience system because we are a resilient people, and
Yeah.
that's our strength that should not be played down by politics, by policy, or by any particular interest. If there is anything, it should be something that we should uplift in the way that we treat each other, in the way that we program things, and in the way that we manage our care system. We should tap into that resilience to understand that sometimes all you need to do is provide the accurate information to move someone from unbelief to a belief environment. And we've seen that happen a lot. People just want to be treated with respect, spoken to with respect, explain things in the language that they would understand, and you will see them making the right decision. But when you come with, I'm the expert here, you should do this, then you would begin to see resistance. And these two things come from the resilient nature of Nigerians. We can be very stubborn people
We are
when we want to
resilient
be.
wherever we go.
Can be very stubborn people.
Honestly.
But we could be the nicest people on earth. It depends just how you tweak our buttons. So thank you so much, Dr. Zainab, for spending this hour with me.
Thank you for
I
inviting
really
me,
enjoy every
for
bit of
having
our
me.
conversation.
I really
And
did as well.
do you have any final words that you want to leave with young doctors like yourselves, advocates, and community leaders that are tuned in here? I've seen a lot of, if I when I look, I just see these doctors, I'm like, oh my God, it's like this is a hub of doctors. Like I did a summit for all doctors. Do you have any words, any encouraging words that you want to leave with them as we wrap up?
I think young people have a lot to contribute to like public health, global health discourse and all of that, and as well as women. I mean, women make the like I want to say 70, I think I saw 70% of the healthcare workforce around the world,
That's an
but
accurate
they're very
data.
scarce in leadership positions. So young people, women, and even other doctors, male and female, should get into advocacy because we are the ones who know the problem.
Mhm.
So we need to get to positions where we can voice out our own concerns and also fight for the things that we believe in.
Thank you.
And
Thank you.
also try as much as possible to make use of social media for good.
That
Yes.
is absolutely important. Thank you so much, Dr. Zainab, for sharing your insights, your stories, and your passion. But most importantly, thank you for being one of the few medical professionals who are delivering scarce care to people in rural and underserved community. You do not know how much I hold all of you at high, regards for staying. And when everybody is jackpying, you guys are staying, and not just staying in the urban health system, but staying in the rural places, delivering care to marginal, forgotten people. So I really appreciate that. Let's keep this conversation going. Please tag us when you share this conversation. We're gonna post it after this, so please share it and tag us and encourage others to follow us. Subscribe to our social media platform. We are on YouTube. We are on different podcast streaming platform, any podcast streaming platform you can imagine. If you type "what about rural health," you will see us there. So please follow us, subscribe to us, and listen. We would repurpose this conversation into a podcast and share it as audio, as well as put it out on our YouTube channel for people to continue to watch. So I would say please follow us, like us. It's the only way we can spread this health promotion is also when you encourage people like us and initiatives like us that take out time to bring awareness to rural health issue. And on that note, I would say thank you for very much for listening and for tuning in. My name is Chinasa Imo, and I go by the handle Ruralist Health. Please follow me and follow What About Rural Health and Dr. Zainab. Thank you so much.
I was waiting to
Bye.
see whether you mentioned my name. Bye bye. Thank you.
Bye
Bye.
bye.